Yeah, I can see numbers kind of creeping up there.
All right, so we'll get started. So welcome everyone to part 2 of our forensic nursing webinar. For those who attended our first forensic nursing webinar, welcome back. And for those who are new, welcome as well. And I'd like to introduce you to our presenter, Sheila Early. Sheila graduated from the University of Saskatchewan School of Nursing and has 4 decades of experience in healthcare. She is currently faculty within the Forensic Science and Technology program at BCIT, acting as a coordinator and instructor in the Forensic Health Sciences option. Sheila also practices as a legal nurse consultant and educator. She has been known as a top leader in the field of forensic nursing, where she developed the first sexual assault nurse examiner program in BC in 1992, performed the first medical forensic examination by a BC nurse examiner in 1994, and developed the first Canadian classroom curriculum for forensic healthcare in 2005. Sheila has also provided the initial education for sexual assault nurse examiners across many Canadian sites, and has provided continuing education both nationally and internationally. So we have about an hour for this webinar. We'll leave about 15 minutes at the end for questions, but if you do have any questions, please feel free to type it in because you are muted right now. There's a taskbar on your right-hand side that says questions. So just type your question in and Sheila will address it either during the webinar or at the end. And if you have any questions or comments, as I said, type it into the question section and we'll address it. So I'll let Sheila take control of the slides.
Okay, thank you, Patrick. Whenever I get introduced, I always kind of want to look around and see who they're talking about because it really doesn't seem like me because, you know, my background is nursing, from mostly emergency nursing until 1992 when I became interested in what we now know as forensic nursing. So those of you out there that have perhaps did not attend the first webinar, I'm just going to go over a couple of things about forensic nursing before we get into the main body of forensic nurses as change agents in healthcare. I spoke actually yesterday to a group of student nurses at Douglas College in Coquitlam, British Columbia, and it was really interesting to hear their perspective on, you know, what is forensic nursing and to confirm and broaden that horizon for them. So I hope to do the same today because when I look at what changes have been made in healthcare since I began in 1992, it is quite significant. And sometimes I think, oh my goodness, we've really done all that. So if you're a forensic nurse now, I hope to give you some details that you can use in other presentations. And if you're interested in forensic nursing, I want to give you the opportunity to see how broad, in depth this particular specialty is. And I use the word specialty because even as we speak, the Canadian Forensic Nurses Association is working towards having it deemed a specialty within the Canadian Nurses Association. So the first thing I want to present to you is what forensic nursing is. And there we go. Okay, so there are many definitions. I'm going to go back to the first one. And I like the one that's actually the simplest and most self-explanatory. It's the practice of nursing globally. And the key word here, not only nursing, but also globally, when healthcare and legal systems intersect. And that's a definition that the International Association of Forensic Nurses adapted in 2008. The wording of forensic often is mistaken to mean police, and that is incorrect. It actually means pertaining to the law, and it comes from the Latin word forensis. And what happened in the Roman times is that individuals would get up on a pedestal, actually, in their marketplace and complain or say good things about certain marketing practices or life happenings. And it came to become what is known as common law. So if a particular merchant was charging more funds for his fruit than another one, they would complain, and then it came down to, okay, everybody's got to abide by the rules kind of thing. So today, it usually means legal or related to the courts. That's the accepted meaning. And it may mean a number of things in different circumstances, because when we have forensic science, we have forensic nursing science, and we have many other components to it. So pertaining to the law is usually what we're looking at today in 2017. I like to say that it collides when we have medicine, nursing, law enforcement, and the legal and judicial systems. They have the same individual, if you want, either the victim or the perpetrator at hand, but we manage our care and our interest in different ways. What is good for nursing a patient may not be the best interest for them for their legal and their judicial needs. And what law enforcement may want to ask us is something that we may or may not be able to provide or do. Another definition, which is a little broader, is the specialty of nursing, which combines forensic aspects of healthcare along with scientific investigation. And what it also talks about is that it's not just patients/survivors, but also perpetrators of violence, abuse, criminal activity, and accidents. So it's not just around sexual violence, which many people now in Canada seem to relate to, because that's one of the roles that has developed over the last 20 years. So the collision course is when nursing/medicine and healthcare come in contact with an individual who has need of law enforcement and or the legal systems. This could be someone who has a work-safe injury and may need to go through a claim. And there are a number of things that happen with that as well. I'm sorry to bounce this around here. It's just a little sensitive. So having just those two brief outlines of what forensic nursing is, I want to go into how things have changed in healthcare for the last 2 decades. I've actually been a registered nurse since 1968. That's coming up to be a long time. And so I've had the opportunity to look at healthcare over decades of time. And yes, the good, bad, and the ugly. I know it's the name of a movie, but it's also the truth about healthcare. There have been ups and downs. I'm not sure today if we're in an up or if we're in a down, and sometimes it's hard to tell. But one thing I do know is what it was like before forensic nursing came on board in caring for patients and what it's like now. And how I know that is because I base it on my own practice and how things are differently. When we look at, first of all, sexually assaulted patients, when we look at that, we see a significant change. Back in the day when I first started working in emergency, it was 1970 actually, and I had my first patient who came and said that she had been not raped, not sexually assaulted, not sexually assaulted, but raped, because that term was used at the time. Sexually assaulted is a much more modern term, if you want. And quite frankly, I had no idea how to manage this patient because it wasn't part of my education. And by that time, I had 4 years of nursing in my nursing program, and I was going back for my last year, which would have given me 5 years of Bachelor of Science in Nursing. So when I looked at it from the perspective of that individual patient, I did not have a clue how to care for her as a nurse. The physician who came to care for her did not have any idea what to do. We followed the direction of a law enforcement officer who brought us what was called a sexual assault kit or rape kit. And so often, professionals had little or no experiences. I was not an exception. I was the norm. Also, there wasn't any recognition that there would be significant findings or something called forensic evidence. The term forensic I never really heard until in the early 1990s. And to document their injuries, well, we documented them medically, and that was it. So when we look at what's happened since, there's now specialized response teams, not in 8 out of the 10 provinces and 1 out of the territories, that have specialized trained healthcare providers who have a response for either from 0 minutes or to 60 minutes. I mean, most of the programs that I know of have about a 45-minute response time, 60 minutes on, for example, bad weather. I know if there's anybody on the call or the webinar from Quebec, I know that you've been hit by a really bad storm. So in that circumstances, obviously things would be delayed. But it's specialized and the response team is documented. Courts have access now to objective evidence that's collected by an individual in a scientific manner. And this was not always the case. In fact, if someone told me what DNA was, which didn't even exist until 1986, I would have just been, deer in the headlights kind of thing. It is objective documentation of the findings that are physical and likely to be needed in criminal proceedings. The key here is that the healthcare provider needs consent from the individual to collect that evidence, because it's not deemed a necessary component of healthcare where, to intervene and for life-threatening circumstances, we have implied consent. You do not have implied consent when you're caring for individuals who are of that patient population I call the forensic population. So we need their consent. And that's why the process may take a little bit longer than anyone can expect, because it has to be an informed consent. And I discussed some of that in the previous webinar. Also, community agencies now collaborate to provide care and follow-up before, during, and after the resources around a sexually assaulted patient's presentation to healthcare. Has that changed how many people have responded to healthcare? I think it has, because we see numbers that are continually going up in the programs that exist across Canada. For example, in 1994, the first full year of the sexual assault program at Surrey Memorial Hospital here in British Columbia, we saw 79 patients. Today, there's over 300 counting, and that is in sight of the fact that there are 2 other programs in the same catchment area. Ontario has 35 centers right now, so they've grown from 1995 to 35 centers. So that explains the need for the specialized care in the sexually assaulted patient field or sexual violence. It's also expanded in it. I'll go into that later for children. So the interpersonal violence patients that present to emergency, they were not recognized as any kind of difference between intentional and unintentional injuries. Often the patient's history did not match what you found as a nurse or as a physician, and yet there was really nothing that you could do about it. You couldn't really say, I think you're lying. You could infer that you didn't believe what they were saying, but if they were adamant in being of adult consent age, you could not go any further. So now we have specialized screening tools for intimate partner violence. And we also have emergency departments that are aware of the high-risk individuals. And we also know that the cost of health care has a huge impact because of intimate partner violence. Colleen Varco, a researcher here out of UBC, has a research project that from 2011 that targeted at $6.9 billion in healthcare funding that is being used for specialized care units. So that's the cost to healthcare, approximately, and that's already 6 years old. So the cost is infinitesimal to healthcare when we deal with violence around intimate partner violence. Also, there's an awareness that it's a public health and safety issue, and it's spreading into areas where we know that public health and safety need to be addressed in that particular area outside acute care. The World Health Organization released a document called Global Action Plan just recently, and if anyone's interested, please send me an email and I'll send you the link, which designates healthcare providers as the front line for dealing with violence, particularly in women and children, as well as others. And it's a 15-year plan to reduce and prevent violence and trauma to individuals. And it's benchmarking countries against themselves, not one country against the other. So those of you that are interested, please let me know, and I will gladly send you that link to the World Health Organization plan. So when we look at the next category, we have child maltreatment. And again, going back to any time before the early 70s, we did not have what we now know as mandatory reporting. Child maltreatment and neglect was often undetected unintentionally by healthcare providers in all healthcare settings. So if a parent came in and said, oh, you know, he fell off the monkey bars, it was taken at face value for a number of reasons. One is ethically, we believed parents, but also socially, we hadn't come to terms with the fact that individuals deliberately hurt children. And because communities were isolated, there wasn't an internet or newspapers that clearly documented every case of child maltreatment that came before the courts. The courts were not publishing information about child maltreatment. I think today we get files that we can keep as reference, and they run the gamut from mild neglect to homicide. So what do we have now since forensic nursing came into the picture? Mandatory reporting came out before forensic nursing, but it also is included in the education of healthcare providers. So now that if you see anything that you suspect as possible abuse to a child, you're mandated to report it. Child abuse teams have formed across Canada with nurses who are actually doing forensic work. Sometimes they may not call it forensic work, but it is. We also have forensic nurses that are now trained in doing sexual assault examinations on children and youth. That is increasing. BCIT, which is my place of employment, and I'll have to get a plug in there for them, is that we offer the only online pediatric examiner course in Canada. And we've actually had physicians and pediatricians taking that course as well. So if you're interested in that, please let me know. We have child ombudspersons within the provincial governments designated to look at the services that child protection services provide. I know that probably those of you that are from BC are very familiar with our child ombudsperson, Mary Ellen Lafont, who actually just moved out of her role, and a new person has been appointed. And if you're interested in long involved case studies that detail the abuse of children within British Columbia, for an example, it's everywhere, it's easy to find. We now have laws that say if you're going to work with children, you need a criminal record check. Is it positively stopping this use of individuals who have criminal records? No, but it's certainly a deterrent. And again, if a criminal check shows up anything that may indicate abuse to children, this is something facilities should and can use. Also, too, we're asked that on our registration forms when, as nurses, we register each year for registration for our license to practice. The next category I wanted to talk about is coming up. Doesn't want to move right this minute. It's actually in-care deaths, and we're going to move this slowly. Patrick, it's not moving. There we go. In-care deaths. Before there was folks who had education around forensic nursing science and practice, often they were, the scene of a death was altered unintentionally, or basically to clean up, by healthcare before an investigation could be completed. Care facilities deaths were often attributed to natural causes and often not investigated due to actually not reporting some of these cases to coroners or medical examiners, depending on what province the individual died in. And coroners in many provinces do not have to have medical training to perform that role. And that exists today. However, more and more continuing education is assisting in that area. What we have now, 25 years later, is that death scenes are preserved by the healthcare provider. They are aware that there's going to be an objective investigation into any care death that is deemed suspicious in any way, shape, or form. Also, the awareness of high incidence of elder abuse in care facilities means that healthcare providers are screened prior to employment, but also to the deaths in non-acute facilities such as nursing homes is also looked at as, is this expected? If it's not, then it's reported to either the coroner or to the medical examiner of the province. Nurse coroners and death investigators who have medical experience now bring that medical expertise to their roles. For example, all you have to do is ask a nurse about a chart, and she'll tell you which records are missing, she or he. So, or what should be on a chart and isn't. So those experienced folks who look at medical records have become crucial in the investigation of, particularly in deaths. Not only in acute care facilities, but in fact in WorkSafe BC and other areas as well. So when we move on to the next one, which is awareness of laws, I just wanted to inform you that, back in the day when I was working in emergency, I had no idea that what I did was often covered by a law. It wasn't part of my expertise. And so when I started looking at forensic healthcare and the fact that laws do impact us, there we go. Sorry about that. Do impact us. And if we don't know them, we're not doing our patients or ourselves the best objective care that we can provide. So now we know such things as the Infants Act if you live in British Columbia, the Freedom of Information and Privacy Act if you live anywhere in Canada and work, also the criminal laws. I mean, I did not know that there was such a thing as a criminal code of Canada. There was law enforcement who arrested you when you did something bad and they took you off to jail. But that isn't what healthcare needs to know. You need to know that certain things are not, that are against the law. For example, there is a law that actually just has been repealed, and it's that you can't give consent for anal intercourse unless you're 18 years old or married. That law just got repealed. So those are the kinds of things that law enforcement may ask of healthcare to investigate, and we shouldn't. There's also the mandatory reporting for professionals regarding both child abuse and also professional practice, meaning that if we see something that individuals within our own profession are not doing appropriately, like stealing drugs, like having practices that are, for example, coming to work under the influence of alcohol or drugs, we need to report those. And that it is important that we look at all our standards and say, am I doing everything I can to keep not only my practice safe, but everybody else's? My job is to be the advocate for the patient. And through that, I need to advocate for the best patient care area possible, no matter where it is. So when we see a sign that isn't there, or should be, over wet floor, we need to deal with it. Especially if those workers out there have fallen and had a work-safe injury. Education around interpersonal violence, sexual assault, sexual violence, elder and child violence and trauma is slowly becoming part of healthcare on many levels. I think the World Health Organization Global Mandate Plan is just the beginning of integrating forensic nursing science principles throughout healthcare. As I said, I was at Douglas College fourth-year nursing students class yesterday, and one of the questions that they didn't ask was, why isn't this part of my nursing curriculum now? Why do I have to bring in a guest speaker? Luckily, their instructor is a forensic nurse, and she's making sure that part of her role as an instructor is going above and beyond. So instructors, have a look at what you're teaching and see if you can somehow integrate any parts of healthcare into healthcare, the principles that we've talked about are talking about today. There's limited documentation before. I can remember looking at charts in the 80s and finding, maybe 2 entries over an 8-hour period. So don't be shocked. It was true. And it was the norm in many places because most places were understaffed or did not have guidelines as to what you should document anyway. Or they had a checklist where you just put a whole bunch of checks on. So limited documentation of trauma injuries by the healthcare provider is the before picture. There was no correlation between mechanism of injury and an actual injury. Oh, so you got a gunshot wound. Oh, okay. The healthcare provider today can tell you whether that gunshot wound was a close range or a long range, because that evidence can be destroyed when we take that clothing off a patient and we throw it in the garbage. which again used to happen. Documentation was often complete or using inappropriate terms or inaccurate terms, was inconsistent, and was not always able to be used by courts. The ones I remember from the 80s, 90s was alcohol on board, drunk. Those were the two. Or seems upset. Those are the ones that came out, and like, how objective are they? What do they really document? They document the healthcare provider's judgment, is what they document, not the actual picture of their patient. So after, what we have is we have forensically trained healthcare providers who document all the findings, whether they think they're important or not, because they have to be done objectively, accurately, and using the correct medical terminology. If any of you are familiar with the initials WNL, within normal limits, that's not an accepted medical term. I happened to use it one day on a documentation on a sexually assaulted patient I cared for. So when I went to court, the defense witness called me to, did his cross-examination on me, and the only thing he wanted to know was, what does WNL stand for? So ethically, I had to say, it's an abbreviation, this is what it means, I shouldn't have used it, and I was incorrect using it. Did that mean I was deemed a worse witness because of that? No. I was an ethical witness saying, I made a mistake, and this is what I should have documented instead. It provides both civil and criminal courts the valuable documentation so that they can be the judge of what is at hand. Not us, not as healthcare providers. So, for example, if you document that a person is slurring their speech, cannot walk unaided to the bathroom to provide a urine sample, repeats the questions even though you've answered them several times, has bloodshot eyes, his blood pressure is low, and his pulse rate is such and such. That's documenting objective, accurate findings, and let someone else decide what they actually mean. And then when you get the blood test to say there's alcohol on board, that just reinforces it. But again, objectiveness and completeness are two things I would really, really encourage every single nurse out there to do. When the students yesterday asked me, about about what things I've learned over the years, I, without hesitation, said, document. Document, document, document. It's kind of like if you're a real estate agent, you say location, location, location. Well, for healthcare providers, it's document, document, document. And remember, we're not the judges. We're only the providers of the information for someone else to make that judgment. Whether it's a medical physician, whether it's a coroner's inquest, whether it's a WorkSafe BC appraiser, whether it's a crash investigator, or someone investigating the death of an individual. Okay? And we're going to move on to the next one, which is workplace safety. And when I look at this, I think, 30 years ago, we didn't even know that we needed to be protected at our workplace. Now we have all sorts of rules and regulations that help us. But in the before picture, injuries and fatalities at work were almost exclusively investigated by non-healthcare professionals who had no idea about medical injuries and what the mechanism of injury could be for an individual. So if a box fell on someone's head, they were more interested in what was in the box rather than, oh, gee, what damage did it cause to the top of the head at the beginning? And the after effects. And I think that's the biggest thing, is that we had no idea the after effects of workplace injuries and fatalities. For those of you who are interested, you could find the article. There's an article written by Colin Harris, who's a work colleague of mine, in the Journal of Forensic Nursing in the issue January, February, about a case study from his work as a workplace investigator. And it talks about a death and how family did not understand what actually happened. And when he investigated the case and was able to explain to them exactly why and how their loved one died, it brought what little closure anyone can have after the death of someone you is a family member or a friend or a relative. So he was the first forensic nurse hired by WorkSafe BC in British Columbia. And unfortunately, he's moved on to another area of forensic nursing. However, the expertise he left there after almost 4 years of work will go on and will keep on adding to the information and the expertise of other investigators who come after him. And let's hope they have the foresight to hire more forensic nurses. When we look at the next slide, it's going to talk to us about corrections nursing. And this is one area where it's really an established area of forensic nursing, both corrections nursing and forensic psychiatric nursing, which did not exist in the 60s and 70s. You nursed in a jail or a prison. It was often called prison nursing at the time. And those folks are dealing with individuals who are on the other side of the victim presentation. So when there's a victim, there's a perpetrator or an assailant, whichever name you want to use. And if they are convicted by a court of law, they will go to jail or a prison. That prison nurse, that corrections nurse, that forensic psychiatric nurse has a duty to her patient, just like the rest of us have to victims. So when they become quasi-specialties and have a name, we now know that they have developed into specialized units. The one that comes to mind is from Saskatoon, Saskatchewan, where my home and my training college was. And there are many forensic nurses are now attached to law enforcement or to emergency departments. Large urban emergency departments now have a forensic psychiatric unit right within the emergency department. And who do you think staffs them? Forensic psychiatric nurses. So that's completely different than it was decades ago. Corrections nursing does cross over to forensic nursing. We're still working on that. As president of the International Association of Forensic Nurses in 2014, I was privileged to sit as part of a task force on corrections nursing, trying to figure out where the link was between forensic nursing per se and the corrections nursing. It didn't quite get worked out. There is a home for corrections nurses within forensic nursing, and we want to make sure that we know that anything to do with pertaining to the law and the judicial system and healthcare is a forensic nurse. So when we look at that, we can see how easy it is to that the forensic nurse can work in many areas, and she might even, or he might be part of 2 specialties. Okay. The next one we're going to go to is the trafficking in human persons, and this one is really near and dear to my heart because when I look at the before picture, let's go back. My mouse sometimes has a mind of its own here. It's just very easy to move ahead, so I hope you bear with me. As I said earlier to Patrick, my technical expertise is limited, and I need my 13-year-old grandson often to help me with things. So when I look at human trafficking, to me this is as big as, or almost as big as, the work in the sexual violence area. Who suspected that there was something called human trafficking back in the 60s when I had the experience of caring for someone who was called a prostitute? I wondered how she could possibly do this work. And she called it. She said, "I'm a working girl." And she had to explain it to me because, you know what, my expertise was nil. No one ever described to me what a quote-unquote working girl was in healthcare. Now I look back and I think, she didn't want to do what she was doing. She was forced into it by the man who brought her in because she had bronchitis. and coughed and coughed and coughed, which was probably not a very good thing when her clients were wanting other areas of her working situation. I have to say that in several years ago, when I first started teaching Introduction to Forensic Health Sciences course, there was a young woman who was a nurse in emergency who had to do a paper on something related to forensics for the class. And she asked me, what can I write about? And I could only say to her, well, it's up to you. And I just said to her, well, you know what? Virginia Lynch, who many of you may know the name, is really what I consider the mother of forensic nursing. And when I took a class from her, I asked her the same question. And she said, write about something you know nothing about, because then you will learn. You will learn. So I chose male sexual assault because I literally knew nothing about it. Males I knew probably were assaulted, but how do you care for them? Was it so different? So I made it my business to do that discussion paper for Virginia Lynch's class. And I pretty much borrowed that technique from her. So when this individual asked me, I said, just write about something you don't know anything about. She chose human trafficking. That young woman was instrumental about 2.5 years ago of developing a human trafficking module for all of Fraser Health Authority here in British Columbia, and is accessible to anyone across the globe. That's what resulted from her doing a paper on human trafficking. So do you not think nurses in this day and age can be game changers? Well, Tara Wilkie, if you're out there or somebody passes on to you, you are a game changer in healthcare because of that paper. So now we have not only nurses but other healthcare providers looking at trafficked persons because they need healthcare. They need a variety of healthcare, sometimes more services than we can provide. But it's the beginning. It's the beginning of saying, we've not met your needs. We need to protect you from communicable diseases, chronic illnesses, injuries, even death. And that toolkit will help all individuals recognize when someone may be trafficked, even if they are not able to say so. When I look back, many of my patients were trafficked. One of the things that happens is that I now work with a number of groups that deal with sex trade workers, because the majority of them do at some point in time want to get out of that particular line of work, if you want. And we have to help them as healthcare providers, because often they're there under duress. And incidentally, which has nothing to do with the topic today, there was a TV show last week rather, and I'll name it, Hawaii Five-0, that dealt with young women being trafficked. And it was pretty realistic. I mean, it certainly was still, drama, high drama. You got to keep us interested in that TV show. But it depicted young women being befriended, groomed, and put into the sex trade. So if you think it's not happening today, think again. So that taught me a whole new respect for individuals who I once called working girls. I've learned differently. They deserve my care just as much as, in fact, more so than anybody else. So I've gone over several things that are highlighting the changes that forensic nursing has made to healthcare. And I've really only documented from, the 90s into the 2000s, which we're in now. But for those of you who missed part one, forensic nurses started here in Canada in 1975. When Dr. John Budd, a medical pathologist out of Calgary, hired nurses to help him with death investigation. So what happened? Why did we drop the ball? I think part of it is that we didn't know how to communicate with each other. Today I can reach out and I can reach 100 people on a webinar if they so choose to have this information as become part of their specialized knowledge. So when I look at how we can move forward, I look to things like webinars. So thank you, ARNBC, for this opportunity. But for each of you out there, I challenge you to have some of your coworkers link in and listen to this webinar. Not because it's me doing it, but because you need that specialized knowledge that I'm sharing with you. When we look at forensic nursing education, decades ago, nursing education didn't address this. I actually kept my pediatric text, and I think child care with injuries was about a page. So that'd be 2 columns in a large textbook. I never suspected that people would make their children sick just to get attention for themselves. We now know that's Munchausen syndrome, and that it's the parent or caregiver that is the ill one, not the child. Children were sexually abused in my day. They continue to be sexually abused as we attend this webinar. Child pornography. I'm jumping to the current side already. Child pornography has become part of our language. Child abuse, sexual assault, forensic nursing, forensic psychiatric nursing were not intimate partner violence. None of those terms were used. Oh, well, you know, she gets beat up by her husband regularly. Well, you know, they do that in that culture. How so is that? Anyone who grew up with an alcoholic, abusive father, husband, brother, sister, cousin, uncle knows that those things changed that individual for the rest of their life. Just like sexual assault does. Just like child abuse does. Just like being beaten every weekend by your husband, your spouse, or your partner. So what do we do now? There's one I forgot to add on the side under courses in Canada, and I will speak to it. Programs in Canada. Now, this isn't self-serving. Unfortunately, it's the truth, and I wish it was not so. That we really, at BCIT, Forensic Health Sciences, have pretty much the only stable program to provide you with education in forensic nursing, forensics healthcare. And it's in the forensic science department. It's not in health sciences. Those of you who I had the privilege to be part of your lives know the long involved story it is why I'm in forensics and not in healthcare. But I encourage you to look at BCIT website. We're offering a couple of courses right now. One starts on March 28th, and it's Introduction to Forensic Health Sciences. And then we have another one starting in April, which is Forensic Health Sciences and Violence and Trauma. The first one, 7810, we can actually stream to facilities. So why? Because we want to spread that knowledge and expertise outside of the Lower Mainland of British Columbia. So if you're in Interior Health or Vancouver Island Health Authority or Northern Health, please let me know, and I'll do everything in my power to see that you get the education that you would be interested in. Other colleges in Canada, Seneca College has offered courses in Forensic Health Sciences. Mount Royal College, which is now a university in Calgary, Alberta, has courses on request. They're now out of the nursing department, and they're not a standalone certificate anymore. There is a course out of University of Saskatchewan, which is forensic psychiatry, and St. Francis Xavier University out of Antigonish, Nova Scotia, which offers a 6-credit forensic nursing course, which is actually an introduction and an education for becoming a nurse examiner. I highly recommend that if you're in the eastern part of Canada. Douglas College has forensic mental health certificate and information that can be found on the Douglas website. Bits and pieces. There's webinars through the Canadian Forensic Nurses Association. They offer 6 per year, with you as a member would get free. The International Association of Forensic Nurses has a number of webinars. Some you pay for, some you get at a discounted rate. The big event happening in 2017 is the International Association of Forensic Nurses Conference in Toronto, Ontario, which is October 11th to 14th. It usually comes to Canada every 5 years or so. This is the third time, actually fourth time it's been held in Canada. So I encourage folks to enter, to look at that. And there's also grants available as well. So there's opportunities out there if you're interested. And if I can stimulate your interest in any way, shape, or form, it's worth every moment of my time. When I look at the next slide, it's about barriers. And there are barriers which we have not overcome. And what that happens is when too many barriers are put in your way, people lose interest. And what we're looking at is a number of barriers. One, of course, which I've already kind of alluded to, and I'm just trying to move my slide ahead here, is lack of it being forensic nursing as a specialty in Canada. This is a huge drawback. In 2007, 3 other individuals, all from Western Canada, formed the Forensic Nursing Society of Canada under the leadership of Kathy Carter-Snell. So there were another one is Janet Callanan, and the third one is Kathleen Soltis out of Edmonton. So we got together and we formed the society, and it was active until it as that name, under that name, till about 2 years ago when it became the Canadian Forensic Nurses Association. Still striving, and as I said, I'm still working even today on that. Forensic nursing is not represented on all levels of healthcare when key decisions are being made. When I went to Geneva, Switzerland in 2015 regarding the Global Action Plan that is now distributed by the World Health Organization, there were only a few forensic nurses there. One was a forensic researcher, and I was actually what I consider the forensic nursing clinician / educator. I was the only one there, and there was 160 some delegates from about 70 countries. So getting at the right table is important. We haven't really even reached the provincial government and the federal government yet. There are many ways we've tried, and I'm talking about a huge number of individuals within the provinces, but it's almost like there's a glass ceiling there. And excuse me for using that term. The lack of educational opportunities in Canada. If you want to get a master's degree in Canada in forensic nursing, it's not going to happen. If you'd have to go to the States, either online or in person. If you want to take a certificate, it's very limited. As I said, BCIT and a couple of others have the formations of different levels of certificates. If you want to have a full-time position in forensic nursing, forensic healthcare, you may find it difficult in some specialties. There's only so many that are nurse coroners. There are only so many that are legal nurse consultants. There are only so many that are nurse examiners in adult, adolescent, pediatrics. Forensic psychiatry and forensic corrections, there are opportunities there. So some of the subspecialties, it's not that easy. The norm is often casual or part-time. Lack of educational funding for the specialized education that is out there. When you're not deemed a specialty, which is the barrier number 1, you don't have access to that funding as a specialty. Whereas if you want to become an emergency nurse or a critical care nurse, there may be funding available through you through different opportunities, such as your union, such as continuing education, or your health region in Canada. So those are, it all kind of hinges on specialty, getting funding, and then jobs, etc., being created. When we look at the future, there are also challenges. And one of the things that happens is that we have to look at many emergency departments, as I consider them the place where forensic nursing really has an opportunity, is they may not have adequate education for the safety and efficient care of their individuals. Henderson identified that in an article, excuse me, in 2014. She said that MDs and RNs don't have adequate education and to provide that safe and efficient care. And because the forensic patient population often comes into emergency about 70% of the time from statistics in other areas. This is one key area that we need to look at, is including that in emergency education. Significance of the ability to healthcare to impact the outcome of both their patients and perpetrators has not been recognized. That was an article by Kathleen Sekula in 2005, and I'll actually send those references to Patrick to post on the website. So it goes back to what I talked about laws and how the awareness by healthcare providers of the laws of the land or the nation, if you want, becoming important to the patient they're caring for. For example, the law to this day in Canada has not convicted anyone under driving under the influence of drugs rather than alcohol. Interesting, isn't it? So you can be under the influence of drugs, but you cannot be charged. You can be charged for other things, like leaving the scene of an accident and that kind of thing. But the expertise to develop testing at the roadside by forensic science is not there yet. There's lack of research in forensic nursing practice, and what that means is that nursing practice needs to change based on research in clinical settings. So, I can probably name the number of Canadian forensic researchers on one hand and maybe a little more. But as we grow those positions and find the questions that we need answers to, that's where the researchers come in. Excuse me. Now we come to the part where I would really like to ask you what questions you have, because we have about 8 minutes, which is a little shorter than I want. Sometimes I get carried away. But if it's not funding, what are some? I don't see any questions out there. Patrick, I see. Yep.
Yeah, just to remind those who signed in later,
Okay.
You want to ask Sheila a question, you can do so by typing it out under the question section on the taskbar that's located on your right-hand side.
And Patrick very nicely sent me a little alert, which I unfortunately ignored, so we have about 7 or 8 minutes, but you can always email me offline too. One of the questions that comes up is, how do I become a forensic nurse? And first of all, I think you need to have an interest in those areas. Take an introduction course from somewhere. Even attending this webinar will maybe help you decide if this is something you're interested in. Take an introduction course. See what it involves, from violence and trauma across the lifespan. You may find, can't do this. Or it may make you even more interested than you already are. Check out websites for the Canadian Forensic Nurses Association, International Association of Forensic Nurses. Those are the 2 key components I can refer you to. There's also another one called Forensic Healthcare Online, which is a blog by Jennifer Markowitz, who's a former president of the International Association of Forensic Nurses. Email somebody that you know is a forensic nurse. I'm easily available on the BCIT website, Sheila_Early@bcit.ca. I'll be glad to answer your questions anytime. And also talk to folks who may know that are already involved in some sort of forensic nursing role. If you're a public health nurse, how to integrate that into your own practice is also something that you ask us, and we'll assist you. Okay. It's okay to ask questions.
One question from a participant, and the question is, what jobs in forensic nursing can you see being developed in the future?
Okay, actually, I see many. I see the nurse examiner role in sexual violence expanding exponentially. And why? Because if we can educate the forensic components to nurse practitioners and physicians, etc., they will become better educated in how to recognize. Not everyone needs to present to an acute care facility for sexual violence in their lifetime, in their life. Some present to family doctors. They have injuries, etc., that are attributed to other things, and to recognize them even in the primary care unit is extremely important. So I see nurse examiners in all areas across the lifespan. I see nurse death investigators as being a role. You don't have to have medical training to become a coroner, but it certainly would help if you have a forensic background. So it's keep applying, keep applying, keep applying if that's something that you choose. I see legal nurse consulting as another area that's growing for two reasons. One is that we're becoming much more legal savvy, if you want. Our patients know a level of expertise and care that should be provided to them, and they're now coming forward in a way that we never even knew could happen, is to the media. They're saying what happened to them in this facility, that facility, etc. We have families that are putting webcams in their loved one's nursing home to see what really happens when they're not there. So those are the areas I think are probably the most likely to have full-time, part-time jobs in the future. Also, educators. You can see by the list I had on the education slide. We need educators. We need people who are have developed that expertise and need to come into programs and expand them into more education. Online education is one way, video streaming is another way. All those need experts who have taken the opportunities that have come forward to them and found them themselves, most likely, and gained that expertise. I hope that answers your question, Kristen. Full-time roles in sexual violence is probably the one that I would target. Psychiatric nursing and forensic corrections, the full-time jobs are already there. Any other questions?
So we just have about, I think, 2 more minutes.
Okay.
One last question is, are there any culturally based courses offered to nurses or other forensic programs?
Actually, one of the things that we do teach in all the courses is that culturally sensitive, and that's no different from mainstream nursing. What has been integrated into forensic health sciences is such things as gang violence, cultural practices which are abusive, or the transition for refugees who come to Canada and the practices that they may have been involved in their home country are against the law here in Canada. So those are the kinds of things that are addressed through all the courses. There is a course that we once delivered on cultural competency within the forensic health sciences. But you know what it did is it differentiated cultures, and what we now basically know is that violence and trauma know no boundaries, cultural, socially, economically, etc. Financially, there are no boundaries. So we have to teach that objective, neutral, competent way across all genders, all cultures, all denominations. We do teach components to the LBGT community, Q community, in the sexual violence courses, because that's very specific to the kind of injuries, etc., that are found in, for example, same-sex assaults. So it's more integrating rather than defining as a separate entity. And I'm sure nursing education has taken leaps and bounds to that area too. So we want to add that forensic layer to it. It's like a building block. So you have your nursing education, and we're going to add the forensic nursing blocks on top of it until you reach the high level where you have an expertise that you can be justly proud of. Is there one more question there, Patrick?
Nope, that was the last one.
Okay.
Yeah. So I think at 2 o'clock. I know Sheila had a bit more slides, but we will be.
think we're done, actually. Oh, okay. You know what? I think those were all covered. I think those we'll just look at. Yeah.
Okay.
I
And
think probably, yeah.
we'll
I
be posting.
addressed them in others. Sorry, Patrick. I think I addressed all of them in talking. So, and certainly people can look at the rest of them online.
Absolutely. So just to let everyone know, we will be archiving this on our website. So if you want to watch it at a later date or have any colleagues who missed the webinar, please feel free to let them know that they can watch this by going to the ARNBC website. And I encourage you to come back and check often for any other webinars that may be coming up. I'd like to thank Sheila so much for her presentation today and for part 1. So if you have any questions related to forensic nursing, please email Sheila. Her email is on the PowerPoint and will be available on the website as well, as I mentioned.
Yeah, and actually the link to the World Health Organization is also on the very last slide for you, so you don't even have to email me for that. And thank you for your time. I'm always appreciative of audiences, no matter where they are, because each of you can now have a look at forensic nursing and expand if you so choose, or just word of mouth. So just share the information. Thank you.
Thank you.
Okay. Thank you, Patrick. Anything more you need from me?
Nope, that's it. Thanks so much, Sheila.
No, and I'm sorry I didn't get the last ones done. You know, sometimes it's all